Hello. In our field, we're constantly managing physiology on the edge. But what about a procedure where we don't just manage it, we actively shape it for a therapeutic goal? That's exactly what we're talking about today, our role in electroconvulsive therapy. Welcome to the Dr. Mech Anesthesiology series. And just a quick reminder, as always, this content is for educational and informational purposes only and isn't a substitute for professional medical advice. Everything we're covering today is drawn from authoritative, peer-reviewed sources and established clinical guidelines. So here's our roadmap. We're going to start by setting the stage for ECT today, then get into the core physiology. What's really happening during that seizure? After that, we'll look at the pharmacology, our key agents, and then talk about technique, how we can actually optimize seizure efficacy. And finally, we'll wrap up with the critical topic of complications and emergency management. All right, let's start with the procedure itself. Anesthesia has completely revolutionized ECT, taking it from its pretty rough early days into the controlled therapeutic intervention we know today. So when we talk about modern ECT, we're talking about modified electroconvulsive therapy, or MECT. And what does modified mean? It means we're inducing that generalized seizure, but it's all done under general anesthesia and with muscle relaxation. And that right there is the game changer. It's what makes the procedure safe by completely preventing the musculoskeletal injuries that were so common in the past. So our job really boils down to three critical goals. Number one, provide complete amnesia for the patient. Number two, ensure their safety with effective muscle blockade. And number three, and this is arguably the trickiest part, is maintaining hemodynamic stability through that intense autonomic storm the seizure is about to unleash. Okay, so let's dig into that physiological challenge. Because really understanding the autonomic response to an ECT-induced seizure, well, that's the absolute key to building a solid anesthetic plan. The main event we're here to manage is this profound biphasic autonomic storm. And I want to be clear, this isn't some minor fluctuation. We're talking about a powerful two-phase physiological surge that puts some serious stress on the cardiovascular system. Our entire strategy, from start to finish, is built around anticipating and managing these two very different phases. Okay, so what are these two phases? Well, right after the stimulus, you get this immediate, intense parasympathetic discharge, a huge vagal surge. This can lead to some pretty profound bradycardia, maybe even a moment of asystole. But here's the thing, it's incredibly brief, lasting only about 10 to 15 seconds. Because right on its heels comes the second phase, a massive sympathetic surge. This is a huge release of catecholamines that causes major tachycardia and hypertension. We're talking up to 40% above baseline. And this phase, it sticks around for a lot longer, maybe 5 to 10 minutes after the seizure ends. So, how do we handle this biphasic response? It all comes down to a very deliberate choice of anesthetic agents. Every drug we use has its own unique profile, and it doesn't just affect hemodynamics, it can actually influence the therapeutic quality of the seizure itself. This table really lays out the trade-offs we have to consider. You've got Methohexital, which is often called the gold standard, mainly because it doesn't mess with seizure duration much, and it helps blunt that sympathetic surge a bit. Then there's Etomidate. It's great for hemodynamic stability and actually prolongs seizure duration, which can be exactly what you need. On the flip side, Propofol is a potent anticonvulsant and will definitely shorten the seizure, so you absolutely have to keep that in mind. And finally, Ketamine. It also prolongs seizure duration and has its own antidepressant effects, but you have to be ready to manage its sympathomimetic properties. Now, for muscle relaxants, succinylcholine is still our go-to. I mean, its super fast onset and ultra-short duration are just perfectly matched for this kind of brief procedure. But of course, for patients who can't get sucks, rocuronium is a fantastic alternative. Especially now with sugamedics, we can reverse it quickly and reliably, getting that neuromuscular function back in no time. And we can get even more nuanced by using combination therapy to play to each agent's strengths. For example, mixing propofol and ketamine can create this nice hemodynamic balance, since their cardiovascular effects kind of cancel each other out. Or you could add a little remifentanil to your propofol. That can help lengthen the seizure. And dexmedetomidine is a great choice for taming that sympathetic response and cutting down on post-procedure agitation. And this is a really important point. Our job here isn't just about putting the patient to sleep. We are actively using our anesthetic techniques to optimize the therapeutic success of the seizure. You are watching the Dr. Mech Explainer series. So what are we aiming for? The therapeutic sweet spot for seizure duration, when you're looking at the EEG, is somewhere between 25 and 75 seconds. Anything shorter than that is often considered suboptimal from a therapeutic standpoint. So that brings up a really practical clinical question, right? You've got a patient with a history of short, maybe inadequate seizures. What can we, as the anesthetist, do to improve that outcome? Well, it turns out we have several really effective tools we can use. First off, you can simply extend the time between giving the induction agent and hitting the button for the stimulus. Waiting more than 2 minutes lets the drug redistribute, so it has less of an anticonvulsant effect. Second, a classic technique, use your bag mask ventilation to make the patient just a little hypocapnic. That's a tried and true way to lower the seizure threshold. And finally, you can simply titrate to a lighter plane of anesthesia. If you're using a BIS monitor, aiming for a score around 65 right before the stimulus is known to result in a longer seizure. Okay, but with any procedure this physiologically intense, we have to be ready for complications. Having a clear emergency management plan is non-negotiable. Thankfully, the most common side effects are usually mild and don't last long. We're talking about things like headaches, some nausea, myalgia, especially if you use succinylcholine, and of course some temporary cognitive fuzziness, which is an expected side effect from both the seizure and the anesthetic. But then there's the big one. It's rare, but it's a true high acuity emergency, the prolonged seizure, or status epilepticus. And when this happens, you have to act immediately and decisively. The management protocol is straightforward. Step 1 is recognition. Any seizure that goes past the 2-minute mark, so 120 seconds, needs to be treated as status. Step 2 is to terminate it pharmacologically, right away. That means pushing an IV benzo or a bolus of Propofol. And while you're doing that, step 3 is to secure the airway and support ventilation, because both the long seizure and the drugs you're giving to stop it are going to cause apnea. And there are other major complications we need to be vigilant for. Those intense hemodynamic swings can trigger cardiovascular events, think ischemia or serious arrhythmias. You can run into airway emergencies like laryngospasm during induction. And finally, be prepared for significant post-ictal agitation or delirium in the recovery room. That needs to be managed carefully. You are watching the Dr. Mech Explainer series. And that really brings us to a final forward-looking thought. As our grasp of neurophysiology and pharmacology gets deeper, the question for all of us is this: how are anesthetic agents and techniques going to keep evolving to make this vital treatment even safer and more effective? You know, our role in ECT is such a perfect example of the anesthetist acting as a true perioperative physician, not just observing, but actively manipulating physiology to get a therapeutic result. Thanks so much for joining me for this explainer. Make sure you subscribe and hit that notification bell to stay up to date with the rest of our series.